The opinions expressed by ResusLogix or Dr. Montano do not necessarily reflect the views or positions of his employer, past or present.
Today, we're moving beyond the standard fluid bolus. We're going to talk about a smarter, more precise way to manage shock using non-invasive hemodynamics. So let's be real. You've been there, right? You have a hypotensive patient and the protocol just screams give a 30 cc per kilo fluid bolus. But have you ever stopped to wonder if that one-size-fits-all approach is actually hurting your patient? I mean, what if you're just pushing someone with a weak heart straight into pulmonary edema? The real question we need to ask is how we can tailor what we're doing to the actual problem in front of us. And to do that, you need a simple framework. It's really powerful. When you're standing at the bedside trying to figure out shock, just break it down into 3 basic parts: the pipes, the pump, and the fluid. Okay, first up, the pipes. This is all about vascular tone. Think about it. Are the patient's blood vessels just wide open and dilated like you'd see in sepsis or anaphylaxis? Or are they totally clamped down? The metric we use to get a handle on this is the Total Peripheral Resistance Index, or TPRI. Next, you've got the pump. This one's pretty straightforward. How well is the heart actually doing its job? Is this a contractility problem, like in cardiogenic shock? For this, our go-to metric is the cardiac index, or CI. It basically tells us how much blood the heart is pumping out, adjusted for the patient's size. And last but not least, there's fluid. This is the patient's volume status. But look, it's not just about asking if they're dry and need more volume. It's really a 2-part question. Are they fluid responsive, meaning will they even benefit from fluids? And just as critical, are they fluid tolerant? Can their system even handle more volume without causing harm? We track this using the Stroke Volume Index, or SVI. So how in the world do we get all these numbers, pipes, pump, and fluid, quickly, right there at the bedside? Well, we use a tool for non-invasive cardiac output monitoring. You've probably seen it, often called NICOM or maybe the Cheetah monitor. The point is, it gives us all these metrics in real time, and you don't have to place a single invasive line. Okay, but this brings up the million-dollar question, doesn't it? How accurate is this thing really? To use this tool like a smart clinician, you have to know what the evidence actually says. And here is the fundamental trade-off. The absolute gold standard is a pulmonary artery catheter. It's accurate, no doubt, but it's also invasive and comes with real risks. On the other hand, non-invasive monitoring like NICOM is super easy and perfectly safe. But, and this is a big but, its accuracy for any single absolute number is, well, it's poor. Just how poor are we talking? Well, a recent meta-analysis in critical care looked at patients in septic shock and found these monitors have a pooled percentage error of 49%. Now, to put that into perspective for you, the accepted threshold for something to be considered accurate is less than 30%. So a 49% error means the number it spits out could be wildly, wildly off. The takeaway from the literature couldn't be clearer. You just cannot hang your hat on the absolute cardiac output number that this device gives you, especially not in a sick septic patient. So listen up, because this is the whole point. The real power of this tool is not in telling you the patient's cardiac index is exactly 2.1. No way. Its power is in showing you what happens after you do something, after you give that fluid bolus, after you start that pressor. Did the stroke volume index jump up by 15%? Did the TPRI budge? That's the data you can actually trust, the trend. All right, so how do we actually put this into practice? Let's walk through a simple, practical workflow you can use on your very next shift. Think of it as a 4-step loop. Step 1, and this is always step 1, is your clinical assessment. Your exam, your POCUS findings, that comes before anything else. Step 2, put the monitor on and get a baseline set of numbers. Don't obsess over them, just get them. Step 3, do something. Give a fluid challenge, start some levo, whatever your clinical judgment tells you to do. And then the most important part, step 4, reassess the trend. Did your intervention do what you thought it would? Did that SVI go up? Did TPRI increase? And then you just repeat the loop. Assess, intervene, reassess the trend. So as you start using this, please avoid these 3 common pitfalls. Number 1, chasing an absolute number. We've talked about this, it's just not reliable. 2, forgetting your clinical exam and your POCUS. This tool is an adjunct, it is not a replacement for your brain. And 3, know its limits. You gotta know that in certain situations like really severe cardiogenic shock, the data can be especially wonky. So if you only remember one thing from all of this, make it this. Use non-invasive hemodynamic monitoring to trend your patient's response to therapy, not to define their exact hemodynamic state.